Essentially, there's a very large clinical trial that started as phase 1. We reported the phase 1 in a JCO paper a year ago. Phase 2 has just been released in the New England Journal of Medicine. At ASH, we wanted to address what we think is quite a hot question in bispecific antibodies, because Glofitamab is unique in that it's a fixed course treatment. We just give it for 12 cycles and then we stop, while other bispecific antibodies are given indefinitely, even for aggressive lymphomas, in spite of the fact that indefinite treatment for aggressive lymphoma is a bit unusual. There isn't really a track record of that being necessary. So we were sort of interested in this question, and we wanted to take a look at essentially a landmark analysis and what happens to patients with a complete remission. So Martin Hutchings, in his oral presentation, presented an analysis of all patients who'd had a complete remission in the phase 1 and the phase 2 portion of the study. So this was a large analysis looking at several hundred patients, both the 155 in the New England Journal, and all the patients who'd been treated in the phase 1 dose escalation, totaling 291 patients. Now, recognizing that patients were treated at a range of doses in that collection of patients, both the step-up doses as low as 600 micrograms every 3 weeks, all the way up to the phase 2 go-forward dose, we still saw a complete remission of 35%, so in range of the 39% that we see at the phase 2 go-forward dose. But recognizing that a significant proportion of these patients were treated at a lower dose, we then analysed what the outcome was for those patients who'd achieved a complete remission. So that's 61 patients who'd achieved a complete remission. Just like we saw in both the phase 1 and the phase 2, of course, the median time to complete remission is short, only 43 days. And what we saw is that essentially patients who achieve a complete remission and retain it all the way out to cycle 12 have a very low chance of losing their complete remission. The 12-month progression-free survival in patients who are in a complete remission at the end of treatment is 92.6%. The 24-month duration of complete response overall is 80%. So we've seen, the reason we did this is because we have multi-year follow-up in patients who were treated at lower doses than the phase 2 go-forward dose. And we're interested in what is the meaning of a complete remission. And what Martin's analysis showed is that if patients get a complete remission on Glofitamab and retain it all the way out to their end of treatment, they're very unlikely to lose that complete remission, at least on the data we have so far. So this is, still probably data that we'd consider not mature. I think most physicians in the area would want years and years of follow-up before we say with absolute confidence that Glofitamab as a fixed course therapy has a curative potential. But the best evidence we have so far is that these patients go into a complete remission at a high rate and retain their complete remission even after treatment cessation, so long as they've retained that complete remission while on treatment. So the majority of attrition of complete remission occurs in the first 6 months, and after that, patients generally do very well. So I think as this data is updated over years, we'll be able to, say more about that. But it really, I think, is the beginnings of addressing this question around fixed course bispecific antibody for relapsed and refractory large B-cell lymphoma, which I think will be an open question for some time, given the competitive environment and the other bispecific antibodies in development. But so far, so good, I think. And I think that's really the message from Martin Hutchings' presentation at ASH.